Our session this morning is on building financial resilience. And if you notice, this is going to be one of our largest panels because everything is powered by money. Ensuring fiscal space to fund preventive and responsive measures to counter shocks and safeguard people against financial distress. I have Dr. John C. Langenbrunner, Expert Advisor, Social Health Insurance, Indonesia. John C. Jack Langenbrunner is a global health financing expert with over 35 years of experience advising governments on health systems reforms, including advising the US government health reforms. Jack's major areas of expertise including health, financing, strategic purchasing, and universal health coverage. Extensively worked in Europe, Middle East, Asia, Africa as a health economist. He formerly led the health economist, he was the lead health economist at the World Bank, where he led the design, development, and implementation of the health sector loan projects in the mid-1990s. Jack served with the Clinton Healthcare Reform Task Force for the White House. He's currently the expert advisor on health reforms, Kingdom of Bahrain, and an expert advisor on social insurance to the government of Indonesia. Chang is the CEO and founder of Ask Health Asia, oversees the company's strategy and direction, ensures overall growth and development. He was with the healthcare systems from 2017 and published by the Commonwealth Fund in London School of Economics. The Epilogue to Affordable Excellence, which documents progress towards sustainable high-quality healthcare in Singapore. Currently used to work with us at Access Health International. Chang is a friend and an ally. Thank you. I have Christopher Benn, Director of Global Health Diplomacy, Geneva. Christoph is currently serving as the Director for Global Health Diplomacy at the Joep Lange Institute based in Geneva. 30 years plus of experience in global health and has been a co-founder of the Global Fund to Fight AIDS. Has toured this country extensively when he was working with the AIDS in terms of making sure that there was awareness. Building on that experience, he's specialized in innovations in healthcare financing and low and middle income countries, and advises several global healthcare organizations. His particular focus is the funding and promotion of responsible, inclusive, and equitable digital transformation of health systems in the country of the Global South. Also is working closely with the G20 in India and was there with Indonesia. Dia, I'm not going to introduce you again because I think it's a privilege to have you on every panel that we can. Thank you. Mr. Gautam Chakravarti is a senior finance specialist in USAID. Gautam has been in the innovative health financing lead at USAID since 2016. The India mission, he manages healthcare loan portfolios guaranteed with banks and financial institutions. He managed USAID's first development impact bond on maternal health, advises USAID's Samrid blended finance facility to respond to India's COVID-19 needs. 26 plus years of experience in health financing and the health systems in India. Before joining the USAID, he has been involved in financing and planning and budgeting for major government India program called the National Urban Health Mission. He's also contributed to improving major pan-India public-private partnerships on emergency response systems under the national health systems. The privilege of introducing Grace Achungara Gura, I hope I have it right. I'm terrible with getting pronunciations on board, is the Health financing lead of the WHO country office in India, where she supports the government's health financing reforms at the union and state levels. Previously, she served with the as the regional advisor for health economics and health financing at the regional office of the WHO Africa and as the health economist at the WHO country office in Uganda. 12 years of experience in public health and health financing in Australia and low and middle income countries in Africa. Several professional interests, which include the universal health coverage, systems reforms, financing policy, economic evaluation, priority setting for public health policy and planning and monitoring and evaluation. Prior to her career in public health, Grace worked as a medical officer in various public and private settings, including the famous Baylor College of Medicine, Children's Foundation, Uganda, a pediatric HIV/AIDS care center. Welcome, Grace. I have with us Mr. HSD Srinivas, who I had the privilege of working with in my previous life, and he's the project director, Health Systems Tata Trust. Srinivas is a healthcare management professional experienced in hospital and pre-hospital setups for the non-profit sector with a focus on PPP engagement. Engaged since 2016 at the Tata Trust as Director of Health Systems, Srinivas has prioritized building, replicating, and scaling models of healthcare delivery, leveraging existing and emerging technologies to overcome supply-side constraints in the primary and preventive healthcare domain. Between 2012 October and 16, worked with Reliance Foundation in Mumbai, initiating development of the Mumbai Outreach Program that connected over 100 underserved areas in Mumbai, the flagship hospital of South Mumbai. He also developed the Asman Alliance in India, a technological intervention to help save mothers and neonates at risk in over 80 facilities in MP and Rajasthan. This financing panel cannot be more robust, and I request our healthcare financing specialist, Maulik, to come over, set the context, and allow the moderator to take forward the conversation. Maulik, I don't see you around here. Oh, right there. He's hiding. And from me, yes. I know.
Thanks, Uma. And the lesser I speak, it's better in front of this expert panel. And also for the reason that it gives more time for a panel for discussion. So as far as setting up the stage, I think so we have been talking since yesterday about resilience and how systems needs to be resilient. And when we talk about control knobs, which can really enhance the resilience of health system, at a community level or a national level, financing becomes a forefront. And what we have seen recently as part of COVID, that after 2009, a financial depression, this is the biggest financial shock that global economy has seen. And I think so this time, the shock is even bigger than what we had seen as far as financial shock was concerned in 2009. So I think so it kind of makes kind of a stronger case of learning and relearning of how to make our financial system more resilient. Because if the systems had learned from 2009, we would have responded better. But we have responded poorly than what we have done earlier. So I think so that makes the case of how to make our financial system resilient. And as an impact of this shock, I think so there has been contraction of GDP of most countries. And I think so now post-COVID era, a lot of efforts are put into kind of how do we make those systems more robust, not only to protect the health risk or financial risk in health outcomes, but also at a livelihood level. So I think the discourse has been moving more from health to kind of overall kind of system level, system strengthening. And when we talk about contraction of GDP, and I think so what constitutes the GDP, I think so there are 4 or 5 kind of things that contributes to GDP, which is consumption of goods, which is investment into infrastructure, it is public expenditure, it exports and imports. And all these different variables comes together as far as contributing to GDP. And COVID has seen that exports have gone down, imports have been affected, and we'll talk about this in supply chain session. The public expenditure has gone down, both in terms of health and in terms of overall kind of social protection programs. And in this case, I think so, there is a lot need to be learned as far as reducing financial barrier. There are also some good learning as far as COVID is concerned. We were able to mobilize additional resources. We were able to kind of decrease financial barriers, and the colleagues from Indonesia can share the kind of learnings from that. There were kind of a lot of support from international financial institutions, and I think there were $38 billion which was mobilized as part of COVID response strategy. And there has been stronger appreciation or more public spending as far as strengthening health system is concerned. And I think so in the morning we had side events where I think so there was a good kind of argument here on there, private spending for public good. And so that's also a powerful argument. It has got pros and cons, but a very powerful argument where the global kind of conversation on financial resilience is going towards. But I think so no one kind of disagree in this group in saying that for resilient health system, one of the strongest lever in pandemic, beyond pandemic, is health financing. And we have got expert panels with varied experience to talk on that. And with this kind of brief overview, may I request John to take over for the session. Thank you, John.
Thank you, Maulik. This is excellent context. Thank you very much. It's a good way to start. I also want to start by saying that the government intervention, international cooperation is really needed as we go forward. So I would say, more generally, healthcare spending has to be counter-cyclical to cope with the substitution of private for public healthcare services. And we really want to maintain and improve access to essential services by the population, especially the poor and the vulnerable, as we've talked about, really being hurt in this crisis. And then we want to preserve health sector spending and employment, which may also provide economic benefits. So with that said, we would like to cover health financing in three levels. Health financing can be thought of as money coming in, number one. Secondly, how you manage and pool that money. And third, how you then allocate it. So to make it friendly, it's a lot like a household budget. There are some significant differences, but it's much like a household budget. You've got money coming in from various sources. You have your income, you have your investments, you have your savings. In healthcare, we know that you have money coming in through general revenues. You may have money coming in through contributions to social health insurance, to private insurance. You may have, especially with COVID, we may see new ways of taxing to bring in more revenue. We have the help from the multilateral organizations, from the philanthropies, from the private sector. So all of these things are very important in thinking about health financing. So that's the revenues part. Now when we go to the pooling and management part, here we get into the issue that we talked about yesterday of excess capacity. Excess capacity. Should we focus on this issue of having some excess capacity for the next crisis, for the next pandemic, or whatever may occur? And if that's the case, do we carve out some of that money to address and to fund that excess capacity, that slack in the system? This is also an area where we talk about public financial management. So in the crisis, some countries, the Minister of Finance, allocated enough money through various means, but that money never got down to the provider level. It was months in some cases before that money got down to the provider level. So what happened there? And that's really an issue of public financial management. And so we can cover that as well in terms of the second level, pooling and management. And then the third level, your household budget. You have money coming in, you decide where to put it. It could be under the pillow, it could be in the bank, it could be in your wallet, whatever. But then how do you spend it? And when you go to the store, you want to buy the best fruits and vegetables, the highest quality at the lowest price. So this is also very important. And I think we can think of the revenues coming in terms of financial resilience, but then also the pooling and the purchasing of services as more of an adaptive resilience. Sunman Kwan yesterday called it agility, the agility that we need in the health financing system to address the pandemic and other issues. So that's where I want to start. That's what I want to give the foundation. And I also want to mention something that Dr. Dia mentioned yesterday, which was she said that in terms of purchasing, a lot of people in Indonesia couldn't get into the hospital because the hospitals were full. They were full. And part of the issue was that they were paying hospitals on a per diem basis. A per diem basis was an incentive for providers to keep people in the hospital longer. So they were actually blocking beds. And so Indonesia was very smart in changing the way they started paying for COVID cases that were admitted to the hospital. And that encouraged a shorter length of stay. It encouraged doctors and nurses to start working together to find the optimal protocols at the lowest cost and to get people in, but then also get them out as quickly as possible. And actually that freed up beds and lessened the challenge. So that's one example of how purchasing can make a difference. So with that, I want to go back to this first aspect of sources of revenues, and I want to ask Christoph first to talk about some of the things that we saw in terms of multilateral agencies, how they supported the crisis in terms of their various lending programs. But the flip side is that they did quite a good job. The IMF, for example, $38 billion, just the IMF alone. I don't have the numbers for every agency, but quite high numbers. At the same time, you know, while they needed that money, and they were very fortunate, and we were all very fortunate to have that money injected into the health system, we now see countries facing higher deficits and longer-term debt issues. So, Christoph, I'm wondering if you could talk us through on not only the money coming in, but now some of the issues that the countries might be facing.
Thanks a lot, Jack, and really an honor to be at this conference and a pleasure to contribute to this important panel. I hope this will, start moving the microphone. You asked me to comment on the role of the multilateral institutions, and I will go into that and explore that with you a little bit. But also to make sure that whatever I say here, you shouldn't just see them as, some global institutions somewhere far away. What we're discussing here is the core topic of this conference. How do we make health systems more resilient? And if we talk about these global institutions and global financing organizations, the goal is the same that I think we all share. We want to make sure that quality health services are made available to every person in need, and particularly for those who, find it difficult to afford that and to avoid that they have to spend out-of-pocket money and fall deeper into poverty. So I think we all share the goal, and there are different roles here. And if you think, well, isn't this all kind of decided more at the national and regional and district and local level? Yes, that's where probably the most important decisions are made about health financing. But the question is, what's the complementary role of these international institutions? So I will give you a couple of examples. There are the two major, international institutions in global health. That's WHO and the World Bank, both created about 75 years ago. So there's no question that these play the key roles here. WHO in particular, and Grace will probably come back to that. WHO has the coordinating role for all of this, the normative guidance, but is not a financing institution itself and needs to be financed well so that they can support the countries in the region. So that's an important point. And WHO is now contemplating for the first time organizing a replenishment themselves so that, WHO is financed so that they can do their job. Then there's the World Bank. Of course, for all the decades, the major financing institutions, major lender for health and development worldwide. But that brings us also to the point that you raised, the debt, level. And we all know, because of COVID, now the inflation, increasing energy prices, food prices, interest rates are rising, and we are facing a veritable debt crisis. Many countries have, not only reached but gone beyond their level of sustainable debt, and that has an effect, of course, on the fiscal space that they will have for health. So we need to address that question. And I think the World Bank is critical for that. And there are currently, big discussions at the global level about debt restructuring and how do we reduce this debt burden. Very popular voice these days is the Prime Minister of Barbados, Mia Mottley, and she and President Macron for France will organize a big summit in June where they will discuss exactly that, debt levels. How can we decrease that? And the World Bank will be critical for that. I would mention one example, concrete example, that I've worked for many years in the Global Fund to fight AIDS, tuberculosis, malaria. One scheme that we developed is debt swaps for health, so that you can get both the creditor and the debtor country together and say, all right, we want to kind of, cancel some of the debt, but we want to make sure that that money is then used for health. So the money goes to the Ministry of Finance in a given country, and with the kind of, debt that has been, canceled, sometimes and often even with a bit of a discount, meaning, let's say $100 million are canceled, but then the Ministry of Finance is asked to pay, let's say, $70 million to the Ministry of Health for the health system strengthening. So that's an interesting model as well. So we need to decrease the overall debt level, but sometimes we can use that directly for financing, health system strengthening. And I would hope that, these organizations can look more into that. But then apart from WHO and the World Bank, over the last 20, 25 years, a number of new institutions have been created to complement this finance. And I will mention 3 examples. The Global Fund, then those organizations that have the mandate to develop products that are important for health systems and for the functioning of healthcare, but where there's not enough incentive for pharmaceutical companies, other companies to develop those programs. But that should be beneficial then for the countries in the end. And also I will touch briefly on the pandemic fund, as we often talk also here at this conference about pandemic preparedness and how we can better finance pandemic preparedness and response in the future. So just on the Global Fund, and again with the question, how do these billions of dollars that the Global Fund mobilizes and allocates really come down to the local level? How do people benefit from that? My answer is, take the example of the supply of commodities, drugs, diagnostics, or in malaria, for example, bed nets. People will never hear about the Global Fund. They don't need to hear about the Global Fund. But in many countries around the world, if people get access to antiretroviral drugs for HIV or tuberculosis diagnostics and tests, or the family can sleep under a mosquito net, in many cases, this will have been provided through the pooled funding of the international community through the Global Fund and then made available to national programs. So it reduces, if you like, the cost of a national health program to purchase. Otherwise, every country would have to purchase these drugs themselves. And not only can the Global Fund, subsidize that, but by pooling that, often we were able to reduce the price for a drug or a diagnostic test or a bed net, by impressive, 50, 60, in some examples, 90%. You pay 90% less if you pool all the resources of the world and then go to the manufacturers, and then you kind of provide that to the country. So that's a concrete example. And as we are talking also, we are here in India. The Global Fund, after the recent replenishment, just made the allocation to India, and it is 500 million for the next 3 years. Now you might say, 500 million, is that important, or dollars? Is that important for a country like India or not? It's still a small amount. So I've always argued it's not the amount itself, but what you purchase and whether the same could happen with money, let's say, that's coming from the Ministry of Health in India. And I think there is a certain advantage. As I said, access to commodities might be easier. And in the case of India, 2/3 of the 500 million will go into the tuberculosis program. And I know from my discussions, the Indian program still says it's very important that we get this money from the international community, because by ourselves, we would not have sufficient resources for tuberculosis, which is a huge problem in India and in other countries. And then they can purchase, commodities, drugs, diagnostics, and so on with that. And one little point that yesterday I was very impressed by Professor Scherini when she mentioned the importance of the communities. And you might say, what do communities have to do with these global financing institutions? But the Global Fund, for example, has always worked very, very closely with the communities of people living with and affected by the diseases. They are sitting on the board, on the global board. They affect the decisions made, but also at the country coordinating mechanism. So and to give voice to these communities, that is sometimes something that an international organization can do and is an added value beyond the monetary value of whatever the organization can provide. Very briefly also on this question of how do we get to new innovative products and what's the incentive structures. If we're talking about neglected diseases, diseases that affect mainly people in poverty, then there's not much incentive for the pharmaceutical companies of the world to develop the drugs, the diagnostics, the vaccines. And that's why over the last 20 years, we've seen the emergence of organizations like CEPI, the Coalition for Epidemic Preparedness. Their mandate is to help develop vaccines for diseases that otherwise would not have much funding for that. They were very helpful then also with the COVID vaccines to accelerate the kind of establishment of that vaccine. Or FIND is the similar organization for diagnostics, or DNDi for drugs for neglected diseases. So these are important that the kind of at the global level, you pool the resources of governments, often also the private sector, private foundations, and with that, you can then develop these products that in the end should benefit everybody, also at the local level. They will never hear about a DNDi or a CEPI, and they don't need to. But the products they might access, have been developed with the kind of pooled funding of the international community. And final point, the pandemic fund created last year under the Indonesian G20 presidency as a response to the COVID pandemic. And we needed an instrument like that because when COVID hit, we've all found there was no instrument that could quickly step in and provide funding for vaccines and diagnostics and therapeutics and so on. So now we have this. It's still, Eloise reminded everybody yesterday how underfunded that is. But it's an example again where that cannot just be done by national health systems. You need a global pool of resources so that we will be better prepared, for the future pandemics. And that is also an example where it needs to be the responsibility of all countries. It's not just a few donors who put their resources together and think this will work. It will not, unless we all take responsibility for that. All countries contribute according to their ability, but also take the ownership and are part of the decision making. We will not get to, these instruments really serving the needs of the people that we need. So these might be a couple of examples where hopefully you could see that yes, there might be, organizations somewhere at the global level based in DC or Geneva, but hopefully they have some relevance also to the country level and the resilient health systems we want to see. Thank you.
Great, Christoph. Now, I like your emphasis on the global level, but also on the community level. And I guess I would ask, sort of quickly, this is a very decentralized region in terms of, only Malaysia and Thailand have relatively centralized healthcare systems. The other countries, whether it be India or Indonesia or China, Vietnam, they're all very decentralized. And so I'm just wondering, are multilateral agencies, you've made this point, but could they do better in the future in terms of reaching down to the province or reaching down to the state, reaching down to the county, even the village? There are thousands of villages that receive funds in Indonesia.
They absolutely need to. And I think there are good examples where we can see how this funding flows really to the community level. But there are countries like India. I always often talk about India as a continent of its own, right? With 1.4 billion people, it's huge. So the real decisions are made at the state level and so on. So from the Global Fund perspective, it was always clear that the resources might flow through the central level, but they have to first get to the state level. That's where the decisions will be made. So that is a challenge, a bigger challenge in a huge country like India. Other examples would be Nigeria, for example, where you have the same, it's a major recipient of international funding and always this challenge to get down to the kind of states and the local level. But I would argue it's not impossible to do. And we are often not talking about cash flow. Yes, there is some cash flow as well. You pay, you know, staff and health facilities and so on. But where it is commodities, and that's the bulk of it, right? Then you have less of this problem because you make commodities available for a country, and that flows in through the state and the districts to the actual health facilities at a kind of much more affordable price than what you would have without these global tools.
Great. Grace, I want to ask you about public financial management, but not yet. I wondered if you, wearing your WHO hat, you're not wearing a hat, but still, you know, if you want to comment briefly on the sort of the global architecture from the WHO standpoint.
Thank you very much, and thank you, Christoph, for that setup. First of all, congratulations on the conclave. I think it's important for us to deep dive into some of these issues. From the WHO standpoint, it's good, one, to see this level of unprecedented attention to pandemic preparedness and response that has happened, of course, in the wake of COVID. Ebola had kind of started that conversation, but COVID really got everyone involved because it affected everyone more than the Ebola epidemic. And I think prior to COVID, we had already begun articulating some of the issues around financing common goods for health. And I think this is one of the spaces that we would want to see, and we're beginning to see a little bit of that coming up at the global level in terms of mobilizing resources around some common goods. So for example, R&D for drugs, vaccines. Some countries in Africa and Asia are not able to sink as much costs into that upfront. So if there is a mechanism for investing in costs like R&D, those are public goods at the end of the day. So that is one of them. The other one was around information systems and surveillance systems. These are goods that many countries in the lead up to the pandemic had neglected. And of course, when the pandemic hit, responding was not as quick because these systems were suffering. And so how facilities like the pandemic fund, the one that IMF is coming up with as well, the global fund money that was repurposed around COVID-19 and other instruments that are coming in, can facilitate in as much as possible the creation of open access, global public goods that then countries can adopt easily or adapt to suit their setting in order to make them respond much further rather than having to sink costs into creating these systems, I think would be important. The other thing, again, going back to what Jack said earlier in terms of going back to the financing principles, really around the fragmentation that we see that comes in with the different pandemic funds. And I think WHO, as you said, Christoph, has a role to play here as a coordinating entity, where at least we harmonize the understanding around the different possibilities with the different facilities that are coming in. The processes in IMF will be different from the processes in World Bank, from the processes in Global Fund, in UN SAF. And so trying to help countries to be able to use this money in a manner that is complementary. What comes from the World Bank complements what is coming from UN SAF, from the IMF Trust on Sustainability and Resilience. I think if we're able to at least achieve some harmony there, that would be very important. As he has said, WHO is also trying to replenish. We don't see ourselves more as an entity that provides financing, but at least in order for us to be able to more efficiently respond to pandemics than we have, there's a need for that dedicated funding, at least for the WHO program, but also for the preparedness side. So there is that discussion going on. The other role we see ourselves is in terms of articulating what the needs are, and I do know there is an effort in terms of trying to understand what the costs, the funding gap would be around preparedness and response for future epidemics. Perhaps when we can articulate that, like we did for UHC with the SDGs, countries can have some reference costs to relate to, so that in their applications for some of these facilities and also their domestic planning, they have something to fall back on.
Great, thank you very much, Grace. So we've talked about the multilaterals. We'll come back to some of the philanthropic organizations. We'll come back to the bilaterals that have some very innovative approaches. But let's not forget that countries are also thinking about revising their tax structure and bringing in more money, improving their fiscal capacity. And one of the more interesting things that I've seen is what's going on in Indonesia now, where Bu Dia's institute has really done some very good work, some very good analytic work on pro-health taxes, sugary beverages and cigarettes, tobacco. You know, as we look back at the high-risk groups of COVID, they were the elderly, they were the people with comorbidities. And really, if we're going to tackle the issue, we really need to think about taxing things that really hurt consumers in terms of their own health. And not only can we bring in more revenues, but there's the opportunity to actually improve health outcomes at the same time. So, Bu Dia, you are the model of resilience. You are on every panel, yesterday and today, so you are the model of resilience. I appreciate that you can come up with every panel and answer lots of different questions from the moderator, and always do a great job. So, over to you.
Thank you, Pak Jack. So I think it's every panel minus 3 or 4, not every panel. And I hope I answered each correctly, because the esteemed colleagues who shared these days with me are experts in their own field. I will try to give some context about tax in Indonesia, health tax. CISD, the institution that I founded and now lead, has been in the, has our focus on health sector only. So our argument always started on the basis of health outcome, health of the population. But especially in these two exercises, studies that we have done, that we are going to still do, we have to build another argument based from economic side, based from not colleagues from the Ministry of Health, but colleagues from Ministry of Finance. And we have to make sure that the products or the outcomes of the studies and our exercise can speak to both and can help colleagues from both ministries speak to each other and to the public more clearly. So on the excise tax, I will start from the tobacco. We had a study done with our colleagues from UIC. It started 4 years ago, more or less, and that study was carried out for approximately 2.5 years until its completion. We found that it's the macroeconomic cost of smoking. We found that the burden is actually Indonesian rupiah 27.7 trillion of disease burden due to smoking. But the revenue received by the government on paper is only 7.4 trillion. So there is a huge gap that still is not being covered. And we come with an argument that actually excise tax can help close the gap. And if Indonesia increase the tax up to 45%, the excise up to 45%, then it's still in net positive. So we are still okay, actually. We have made 2 major breakthroughs in this study, in this particular study. One, we finally managed to speak to our colleagues in the MOF, even though all of us in the institution and all of us, well, our colleagues from UIC are mostly health economics, of course, and we build capacity from this collaboration. We as in CHISD build capacity from this collaboration. And we managed to speak and to know how to speak to our MOF colleagues regarding this and having trust built. So our outcome of the study is being referenced as the Ministry of Finance increase the excise tax. So from 45%, it has been increased twice. First is 10%, and then this year another 10%. And this is a major breakthrough because Indonesia is going through our political year, and usually in the political year, governments are hesitant to increase excise tax. But this time, they increase it because they know it's still, the cap, the ceiling is still 45%. Of course, we are happy that this is a success, more or less, but revisiting your question about sweet and sugary beverages, we are now embarking on a similar path in the sweetened beverage. So we want to have a similar study conducted where we can present the government again with numbers and so they can see the space where excise tax can be exercised on in sweetened beverage. The talk about sweet sugary beverage has been in Indonesia for more than 6 years at the very least. But there is no major breakthrough on increasing or implementing an exact number high enough for excise tax. And we think in CISD that this is timely because the government is trying to find money to make sure that the state budget and the subnational budget can go down to community like what Christoph said, and also to make sure that there is a supplemental budget for communities to work on. So it does not, the health budget that is not stuck with whatever amount is being given through the state budget, but there is a buffer to add more and to, of course, decrease consumption, but also give more fiscal space for health.
Thank you very much. I think it's the time for pro-health taxes, and I would hope that many countries now look very seriously at both the tax on cigarettes and smoking, but also the tax on sweet and sugary beverages. And I've got a few other ideas if you're interested on what could be taxed. But certainly the issue of good nutrition is a big one, and this is the time we should look very seriously at this. We don't want to tax things that will hurt macroeconomic growth. But I think this is something that won't hurt macroeconomic growth, but instead will improve health outcomes overall. Let's keep moving because we have a big panel, and there's a lot to learn from our excellent panel. I want to move next to Gautam. Gautam, access to capital during the time of risk is a big challenge for the private sector. I went to a presentation on some of the blended financing innovations that your team has been working on, and I'm wondering if you could tell us a bit about it and how successful it has been. And I think this is, there are different variants of these blended financing models that are now floating around to different agencies, and I think it's something that people would be very interested in. So over to you.
Thanks, Jack, and thanks also that you mentioned that blended finance, because yeah, that's one of the key themes that I would really love to highlight. But maybe before that, let me actually come to this. And also nowadays we keep hearing about blended finance as if like it's blended training, so blended has become a catchword. So trying to a bit deconstruct this and why we are talking about blended finance or these kind of approaches, especially if we look at from the need. And I think in this panel, in these 2 days also, we are basically talking about the need for health systems resilience. So blended finance is a very catchword and broad thing, but what do you need that finance for defines how do you structure blended finance, and that is where I'll also come down that in USAID how we created the blended finance, especially as a response to the COVID thing. Now, when we talk of private finance, I think one of the major arguments had been that whenever a country or globally also we face a shock, we always see that it's the public system that is providing the essence of the resistance as well as the service delivery and all. And therefore, is there any scope of private finance? And therefore, is there any scope for blended finance and those sort of things? But I believe even if we assume, for instance, the entire healthcare provisioning is done 100% by the government, so it is a public system 100%, still that public system needs private production of goods, services, and commodities to really provide those services. So you will never have a situation where private financing, especially when it comes to health, is absolutely on the sidelines. It is needed even for government to provide services. Now, establishing that, when we come to why do we need financing, and especially when we talk of health system resilience, I think what we have learned in this COVID, and that is where we created this blended finance also, the needs are very different. The way you run a fully functional and efficient health system is a little different from how do you create a resilient thing. And what I also keep talking about in my circles is very much like the regular health system is very much like keeping the regular law and order by an efficient police. But efficient police is absolutely ineffective if there is an external aggression. You need kinetic operations by the military. So the way you provide or prepare for resilience is a little different from the way you maintain an efficient health system. And we have seen in COVID even countries where advanced health systems, South Korea, Europe, US, had faced problems. Everybody faced problems. So if we deconstruct this, what is it that we need the system to do for resilience, and therefore what kind of financing we need? I think what we came up with or understood is essentially we are talking about two kinds of need when we talk of health system resilience. One is how do we finance redundancies? Because to respond to shock, you need redundant systems and redundant assets. Maybe assets with multiple use, but definitely when it comes to system redundancies is a need for responding to unforeseen shock. But creating redundancies means you will have assets and systems which in natural course of time will not be either providing services or will be a little suboptimally used, and therefore if you look at the revenue stream, it will be a little subdued or zero revenue. So how do you create or finance a thing that will be used at some point of time, maybe for a short period of time, we may say 1 or 2 years also short period in that sense, but will not be producing continuous revenue stream. So that is one. Secondly, we need financing for resilience for surge capacity. Now surge capacity also means there will be a sudden increase in the stock of both goods and services and maybe human resource skills and all those sets also. But once you have this increased stock, the drawing down of these stocks will be again for a limited period of time and will not be for 10 years, 15 years, 8 years, maybe a few months and a year. Which comes to, when it comes to private financing, the regular private financing will be very, very averse to touch financing such things because the revenue forecast is absolutely uncertain beyond a few months. Also, when we talk of the special type of private financing, which is impact investments and patient capital, they are also looking at 10-year plus horizon. But if we are talking of maximum 6 months, 1 year, 1.5 years, again, they are very reluctant to touch it. So then what are the alternatives? So as an alternative instrument, what we have seen globally, especially for COVID, is something like the advanced market commitments. And that had been a major tool to finance all the vaccines. So you need to ensure at least some big volume for private sector to invest and have some idea about the expected revenues and therefore get into production of those things. But the another area which had been quite neglected, and that is where USAID came up with the blended finance, is the need to de-risk. Because suddenly when you have this surge capacity and a big stock created, it might not be selling. So you might need some money to de-risk the uncertainties around the revenues of those things. So for de-risking, and not just de-risking, but also in terms of shock, you would also need the private sector along with the public system to do some sort of affirmative action, reach out to unreached and those sort of things, which will not produce any revenues. So you need some mix along with the private investment, debt and equity, some grant also to come in, which is not returnable, which can provide the risk guarantee as well as take care of those affirmative actions. And that is where the Samrid blended finance that we had come up with, and it was actually a ask from the National Health Authority in India. So they asked us if we can help create that. So we created it, and what it actually meant, it's more almost like $300 million fund now, mostly funding various healthcare innovations. So not the vaccines, but more like devices and approaches and products and all those things, the drones and those sort of things. So this $300 million have around 30 million of USAID grants. But with that, we could leverage 270 of mainly debt capital. And what we have also seen, like again, blended finance is a broad umbrella of various instruments. So most of the instruments that had been used is the de-risking part, either partial loan guarantees or full loan guarantees. But along with that, what has really worked, and that is a very rarely used instrument, but we have seen it especially during COVID, is a portfolio level social success note, where through USAID grants, we guarantee at least partial interest payment. So if the interest is around, say, 18%, 20% rate of interest for these new innovations, we say half of that we will pay, but with the condition that innovations reach either the last mile in the tribal areas or urban slums, or it is like placed and operationalized in the government facility. So it's a conditional risk cover for the banks, but with that, actually we have SDFC, we have Axis Bank, total putting together almost like $200 million of debt against a portfolio level kind of risk cover, conditional risk cover. So with that, I think we were really able to mobilize a good amount of private investments, especially debt, which could not have come if we didn't have these kind of instruments. And actually, maybe we can talk about it a little bit later on. But from the policy level, from the government level, we need certain policy frameworks which allows these kind of blended finance. We have the social stock exchange up and running, but we very clearly see that social entrepreneurs who are for profit can only raise debt and equity. They can't raise that zero coupon, zero interest, which is essentially a grant. They can't raise that. But if we don't have this kind of policy allowance for mixing grant along with debt and equity, especially for social purposes, I think a big area of private sector leverage would be lost. So with that, maybe I close and we can come later also.
Gautam, thank you. And I would follow up by asking, you work for an international organization. This is a model that we see in India. It's a very interesting model. Do you think it has generalizability? Do you think it's a model that could be tested and used in other countries?
Yeah, definitely. Actually, along with this, and I think you were in one of those presentations, we had been interacting with countries like Nigeria, we had been interacting with countries like Indonesia, and also with USA at global level. We very strongly believe when it comes to financing, we are not limited by geography, because financing is a global phenomenon. So you can actually have a financing platform or structure to global financing structures to address local issues, which I think various multilateral agencies are also trying to do. So let me give an example. We have social stock exchange. Now, since last 2-3 weeks, it is functional under the National Stock Exchange. This, who can raise money from here, is actually global. So anybody who can raise, so if you have a platform in some of the countries, earlier we were actually looking at either London for charity bonds or the Singapore Stock Exchange for development impact bonds. So you have platforms at various points in the global arena, but you can leverage that to bring that money to the local issues. So even if an innovation is in India as a blended finance, I think we can really support. In fact, the Samrid finance, the blended finance, is actually working in East Africa, especially Kenya, and we already have 3 blended finance structures up and running there to support the vaccine supply chain. So blended, when it comes to finance, like there are no boundaries. We can go global with that.
Good, thank you very much. And we may come back to you either in discussion or with questions, okay? So thank you very much. I want to move to Srinivas. Srinivas, you and I share something. We have both worked for philanthropic organizations. I'm past tense, you're present tense. You know, something we think about in philanthropic organizations is, you know, first of all, partnerships. Very important to have partnerships in philanthropic organizations. You don't want to go alone. You really want to do it with key partners where you can make a difference. Secondly, you really want to think about sustainability, right? You don't want this to be a one-time thing. And one of the interesting things during the pandemic was that countries did quite well in the first year of the pandemic in terms of finding resources. But there's a lot of literature and different information out there that countries faltered a bit in years 2 and 3. So they did well in years 1, but they didn't do quite as well in years 2 and 3. And so sustainability is a big issue. It's a big issue in terms of revenues, but also a big issue in terms of program impact. And that's sort of the third area that I think we really think about very closely in the philanthropy field, because often it's difficult to measure. Often we don't have the evaluation tools or programs, but nevertheless we do want to see that impact. So I'm wondering if you could talk to us about some of the experience that you've seen in Tata Trust and how you've contributed to the overall response in terms of resilience in financing.
Thank you so much, Jack, and glad to be here and share some of the experiences over the last 3 years. I think this has been a very unique time in the history of mankind, at least in our generations. I don't think we have been only reading about what has happened during a century ago, but to live through this, it's very interesting, multiple lessons that we have learned. One of the largest philanthropic contributions came from the Tata Group. This is, of course, not a very big amount compared to what the governments would have spent in India, but around $200 million is approximately what was committed and spent by the group under various initiatives. To your question, Jack, the year 1, year 2. Year 1 was all about uncertainty. Nobody really knew what was coming on top of us. There was some anticipation during February because of what's happened in China a couple of months ago. But March, when it was actually declared a pandemic, March 2020, I think the one good thing with the philanthropy where I work was that we were able to react pretty quickly compared to what the government response followed. So it wasn't really major planning for the next 3 years or 5 years, how it will sustain. But the immediate need at that point of time was to, purchasing goods, and that was available only probably in China at that point of time, when the entire world was facing the issue and China was the only supplier probably. And we were able to pretty quickly get the things going and import almost 570 tons of PPE. That was the need of the hour at that point of time. And then, of course, the Indian government's policy response was pretty fantastic 2 months down the line. That whatever was required for the country was not only produced, but subsequently, exported too. But what I meant was the philanthropy finance helped quickly react to a particular situation. We also invested into developing some model hospitals, because COVID wasn't really something which was unique. So most of the private sector was kept off. It fell totally on the public sector, the public health institutions to manage this. Also, the government was not wanting the private to come in. WHO had published a few of the guidelines as to how you should, how do you test, track, treat the patients. So some facility level interventions had to be undertaken. That was the year 1, and it wasn't really done with any thinking of how would it sustain. It was meant that, okay, let's first tide over this particular crisis. But year 2 gave us some ideas. When the second wave came and there were still some infrastructural issues. India luckily overcame the challenges of year one, I think probably because of the complete lockdown, as well as definitely leveraging the huge public health workforce. I think the first wave was more of public health response. The second wave hit the facilities actually. When I'm saying public health, I meant the frontline health workers who did a lot of work to contain the epidemic in the local areas. But wave two was not manageable. It hit the public health facilities, it hit the health systems. That's where we were overwhelmed. So that's when we actually thought through what is it that we should be spending money, because compared to what the governments do, ours is meant to be sort of catalytic, supposed to leverage what is already happening, and therefore what is the best way, because by then you were also answerable to the auditors. So what we looked at was the adaptability in the system. Which of the organizations, which of the hospitals were really willing to repurpose their own existing facilities, and therefore that's where instead of starting from ground zero, we actually helped finance some of the augmentation of facilities, where even say a gynec facility was ready to accept a COVID patient, provided they got about say 5–10% of their existing infrastructure as an additional thing. So that made a lot of sense than starting everything all over again. So adaptability, and then the need and requirements. A lot of urban areas were pretty well served, but tier 2, tier 3 locations is where we also focused on spending our money. And of course, most of the time, this was tied up in terms of leveraging what's already being planned from the government. So there was definitely some learnings from the year one we brought into year two. And I guess that's what has happened in a lot of places, both in government as well as in other philanthropic organizations too.
Great. And I like your discussion about the private sector as well. So you bring together the government, the private sector, and the philanthropic track. So quite interesting and quite good. So I want to continue that focus on the private sector, and I come over to Cheng Lu. Cheng Lu, thank you for your patience. When I worked in China 15 years ago, the Chinese people were very impatient. They were in a hurry. They were in a hurry to change their healthcare system. They were in a hurry to bring about universal health coverage. And in a matter of a few years, they moved to, I think, 95–97% in terms of universal health coverage. And, I really enjoyed working in China because people always said, what's taking so long? What's taking so long? We're in a hurry. We need to change things. And one of the things they were doing was not only moving more money into the social health insurance programs, but also thinking about how they could have a more diverse public and private sector. So I'd be very interested to hear from you about, because it's been several years now since I've been in China, regretfully, but I'm very interested to hear about what the progress has been in China and also in Singapore, because I know Singapore has done some very interesting reforms there as well. So over to you. Thank you.
Thank you. Thank you for the question. It's a great pleasure to be here. I think one thing you just said, doing about 15 years ago when China just embarking its health financing reform, the new wave, one thing they did, I think, really right is set up a multi-layered model. So that's even lasting. So although the core focus of development in the last 10 years, in the first 10 years, is on basic medical insurance, but the structure is already set in the very beginning that it's going to be multi-layered. So I think on the national level health financing, the role of the private sector is smaller, like this chair, but I really want to argue it is still an important one. And because it's offered the flexibility and complementary to the sort of bigger public health financing. So the goal, I think, for health financing, everyone must agree, are like building a sustainable, I will add multi-layered, value-based, and equitable financing. I think private sector financing potentially can play a role in all this, achieving all these goals. So I personally took the Singapore citizenship about 5 years ago. I think the main reason for that, because I really have the confidence to the government because of their long-term planning. So I think that's why Singapore government, although it's like top 3 richest nation in the world, whenever they're making the policy planning, especially in financing, they're thinking about long-term sustainability. So can we afford this policy? If we can afford it now, but that's not going to be determined if they will launch this, right? They need to think about, would they last in the next 10 years, 30 years? With the population aging and everything, if I offer this benefit to our people, I don't want to take it back because people will be very mad. I want this policy to be able to last for 30 years, right? So they're extremely careful in, so that's also why Singapore is also have that more multi-layered model where private sector has a very important role. So I think same thing I observe in both Singapore and in China is that whenever the public payer, because it's all universal care, but the benefit package is limited, it's not covering everything. Whenever they decided to add anything into their benefit package, they think about budget impact for now and for the next 10 years, right? So I think in this setup, the private sector really offer an important role because it's a buffer. So there's always that buffer layer. The government say, okay, I can offer this now, but then maybe in 10 years, I have the private sector grow a little bit more, so I still maintain my sustainability. So I think that's the first point. I feel the private sector financing can really adding to the long-term vision of our healthcare financing through the sustainability. But I think the way to achieve that is really needed to be complementary rather than substitute the private financing role. So but to be able to achieve that, the public sector really need to lead that structure to guide how private sector play the role instead of letting them become their own silo, right? So we even look at the Germany model that the private sector player, they don't even participating in the public financing. That's what we really hope everyone actually contributing to the universal healthcare budget, right? So that's first point. I think on the multi-layered model, we observe some really good examples in Singapore and in China that private sector financing really made a big difference. So in Singapore, for instance, the integrated shield plan. I don't know, I think many of us might not be aware of that program. That's basically private sector run insurance building upon the UHC in Singapore. So because the universal public financing only cover a fraction of the benefits, this governmental set up private sector insurance program now actually over 90% Singaporean have. So it's additional health financing that private adding to the benefit package to the people, right? And it's still growing the benefits. I'm actually very proud that we have been in the last 4 years, 5 years to boost similar model in China. So it's called city supplementary medical insurance. Now even going to the provincial level. So we really want to recommend that everyone to look into that public-private partnership model. So after 4 years now the very affordable private insurance, commercial insurance program covers now over 100 million people in China. And then itself raised about $3 billion USD per year, that growing at 100% pace, right? So imagine, I think that's the power of private sector sustainability. I think for us as a smaller organization, not so powerful as the lady I sit next to. So I think the benefit of growing the private sector financing is that we don't need to take away any people's cheese. We're really trying to grow the pie, right? Like this is really, no one is hurt in creating this new financing mechanism. Actually, many people can be benefited from. And then, but that's more for the middle class. But there are also 2 other very exciting models that we see in the last 2 years. One is the mutual insurance in China. That's almost like less than $5 per year. It's organized through technology to bring over 150 million people in China for the poor, many of them are poor population, to be able to have additional layer of house financing. And another model is crowdfunding, also leveraging technology platform. I think now they raise even more funding to the safety net than the public budget to the safety net. Right? That's very, very significant. So I think all those models actually can have the potential to transfer to other developing nations. We already see, actually, we brought the first mutual financing model into Indonesia a few years ago. But I think the crowdfunding and others also have the benefit. And the third point is on value-based. I don't want to go into too much, but I think the strategic purchasing is difficult. And then for government, it's also privatization on what different fields. What we see in China is that many of the charities and also the private sector, they're adding into the value assessment. So they provide evidence to the government to see, okay, this is the evidence you need to, like Gates Foundation, they did in vaccine, right? You really need to prioritize in your budget. So because government, you cannot just rely on them to do collecting all the evidence themselves. And lastly, more equitable. I think it's unfortunate, I think almost all nations cannot have absolute equitable health financing, even in Singapore or China. But I think the participation of the private sector might be able to enhance the layer of the common level of benefit. So basically, the upper middle income can be covered by commercial housing insurance, but it's still contributing to the general pool, and then the charity going to the bottom of the pyramid to add into the safety net. So in that way, the average benefit package can be improved overall for the entire country. But I think for this, I have a comment. Sometimes the government, the mistake I observe is they use their budget for subsidy to the pool, misuse them. For instance, in long-term care insurance planning in China, they put the budget for subsidy directly to the entire premium pool. That's why I really feel they should always, the government's role always need to save some budget for safety net, right, for subsidy to the poor population instead of just rushing to create some program and putting the money into the general pool. Anyway, so that's all my comments. Thank you.
So on this issue, thank you, Cheng Lu. On this issue of pooling, now, one of the things the Chinese recognized as they moved to universal health coverage was that money was pooled at local levels in counties. And they realized that county by county, you could drive from one county to the next, and the pool would be vastly different. And so, you know, they then embarked on a process of trying to pool that money at a provincial or state level, right? And I'm just wondering, did that have a positive impact when COVID came along, when the pandemic came along, in terms of actually being able to give access to the poor and vulnerable groups, the rural versus the urban?
I think they're gradually sort of elevating the pooling areas in China, but they realize it's difficult, right? It's always sort of political to do that. But I think the current direction for them is to sort of smooth out the benefit package across the nation. So they created a benefit list that's a national level, so everyone need to obey. But that's also sort of a space for the private sector, right? Both the commercial housing insurance and the charity, then they can still offer that differentiation in terms of benefit, or maybe the CHI is more on the differentiation across the region, while the charity towards that redistribution. So I think that's also the role that the private sectors be able to play in smooth out the benefit packages nationally.
Okay, so we've sort of traversed a wide range of ways to bring in new revenues, right? From a very traditional government base, we talked about the private sector, we talked about the multilaterals, we talked about the bilaterals and the blended financing model, we talked about the philanthropy model. So we've talked about a number of ways that countries can think about bringing in new revenues, and we started to touch a little bit on pooling and management. And now I want to come back to Grace, because one of the challenges during the pandemic was that the Minister of Finance would allocate the money, but the money in terms of actually reaching the provider, actually reaching the patient, would take months. And I'm not sure what the problems were, but I know that Grace has done some examination in a few countries, and I'm wondering if you could help us, Grace, in terms of what was learned and what we can do better going forward.
Okay, thank you. I just want to say, first of all, that the public financial management system plays a huge role in this discussion, because whether it's handling the monies that will come from the global financing mechanisms that are there, whether it's handling the engagement with the private sector providers, as you rightly said, or managing across the health sector, two other sectors that are instrumental in a successful response, but also from a preparedness function. The public financial management system plays a big role. We have argued as WHO that both for UHC, but also for health security, we need to have a predominance of public spending, whether it's domestic or coming from the global level, public spending. But also, it should take into account the intersectoral nature. And I believe the public financial management system has a huge role to play, both on the revenue raising side, but also on the expenditure management and accountability side. And how that plays out, I'm going to look at it more from the legal policy environment, the system itself, and then the human resource capacities that are needed for preparedness. And so on the revenue raising side, of course, you need to have one of the lessons that at least we saw coming out of Ebola, but also the COVID-19 experience, was the need for enabling legal instruments, whether they are regulations or acts that can be used to mobilize additional revenue very quickly. So whether it is a supplementary budget that is come, whether it is to reconvene the parliament in order to be able to put into place such an instrument, all that is very important. The other thing is the planning capacity, which unfortunately in many countries, particularly decentralized ones like India, where health is a state subject, you find that the planning capacity, both for UHC but also for health security, is limited. And with the pandemic preparedness and response, now it also requires convening other sectors that normally health wouldn't interact with. And so the planning capacity in that regard is something that has to be built up in the lead up to response while we are working on preparedness. And so that is one element. And the other thing is how the budget structure enables this joint planning. So the program budget structure provides at least potentially that kind of platform in many countries like South Africa, New Zealand, where we saw them able to mobilize different sectors much quicker in that regard to jointly plan, especially around some of the common goods like medical waste and wash, and how it had implications there, urban health, and so on and so forth. So the budget structure as well plays a huge role in the planning and process for the budgeting. That is something that also needs to be strengthened. With regard to the execution phase of the budget, I think that is one area where across the board many countries really, especially in the lower middle income countries, we see a lot of challenges in absorbing money, and even money that is mobilized during the response phase tends to get stuck. And issues there really are around approval mechanisms, are around the rules within the PFM that allow reprioritization across priorities. So systems that already have mechanisms that relax PFM rules during emergencies were the ones that were able to respond much faster. So for instance, countries that were able to relax virement, so like for instance, India was able to relax from 10% to 25%. That helped move monies a little bit faster. Systems that were able to relax laws or rules around procurement, whereby where there's a preference for particular sources, now they were able to open up to more people that could supply, more suppliers, or were also able to shorten the procurement process in terms of the approvals needed. That also helped to move monies faster. So if you have, on top of the routine processes, systems that can enable that fast tracking during pandemic response, that can help as well. In addition to that, when you have contingency funds, like pandemic response funds, some countries did have that, and with rules around when you can trigger the release of those funds, that also helped. On the the other side also on execution as well, facilities that countries that had within their pre-FM processes mechanisms for contracting partners like the private sector providers were able to mobilize that additional capacity that was in that sector to buttress what was coming from the public sector. I remember during the response, I kept getting many calls from the state health authorities because they needed to be able to get on board some private sector providers, but they did not have them in their systems, and so they were wondering what guidance was available. So in countries where already there are mechanisms to engage with the private sector providers within the PFM system through the different provider payment mechanisms, whether it is capitation and all, that also helps in increasing the surge capacity, mobilizing it very quickly. In addition, mechanisms for paying health workers that act as surge capacity during that time, because sometimes you have to bring on non-contractual staff, but also have to incentivize the ones that you already have, as we are seeing many countries doing so. So mechanisms that countries that are able to put in place mechanisms for paying those bonuses or incentives moved a bit faster. So in the lead up, in terms of strengthening PFM systems, I think that is another area. The other thing is increasing the flexibility and autonomy at decision-making process at the health sector. I mean, the health providers level is also important. And where you find less rigidity at that level, it's very easy to move money. And there are countries that have already put in place systems like that, for instance, for straight-through processing, where you're able to send money directly to the facilities so that they can easily deliver, but also direct facility financing, where you've already created some sort of increased decision-making space at the service provider level. They are able to reallocate some funding, but they also have the ability to order according to how they see the local priorities are. That is another area that can be leveraged in the lead up to, as we are strengthening PFM systems. Also increasing financial ability for financial accountability. That means having systems devolved towards the lower levels of the health system at health facility levels. Many countries, these stop at higher levels of the system. But if a primary health care center is able to have maybe some sort of electronic reporting system in order to be able to account better for financing, that really helps in terms of PFM. So.
Great. Great, thank you. Thank you, Grace. And so I'm going to open it up for questions. And I think that, you know, to summarize a bit, we've talked about sources of financing, and this is really all about financing resilience. We've talked a little bit about pooling and management and purchasing, and that's really all about adaptive resilience or agility, as Sunman Kwan said yesterday. But then I also think we need to use health financing to create a dynamic of change in the healthcare system, because the health sector is probably the most dynamic sector that we can imagine. I mean, every week you can pick up a journal and read about new drugs, new devices, new procedures. And so the health sector has to constantly change in response to these new things coming online, as well as the changing nature of the disease burden, right? So we've talked over the past couple of days about the benefit package, but we also need to think constantly about how we can use health financing to create the dynamic of constant change. I go to many countries where there's a big reform, and then for 10 years, nothing happens. And then they're behind, and then they're behind, and they're not ready for the next crisis. So we can't let that happen. And so I've heard people call this the transformational resilience. So just to put that on the table. So let's open it for questions. Yes, Vijay.
So a great panel. I really loved what you talked about. So a couple of things that cause a little bit of heartburn for me as a provider in multiple different countries. When I encounter anybody who talks about money, we call them in the healthcare industry the bean counters. And, and every time you're talking about efficiency, which translates into knowing the price of everything and the value of nothing. That's one. And the second part that I heard a lot about different modes of financing. And let me tell you that to a simpleton like me, I'm just a dumb ID doc, it sounds a lot like crisis management. To me, a resilient system, particularly a complex adaptive system, must be both autocatalytic and autopoietic and responsive. So I didn't hear that.
Who wants to answer that question? I think I put it a little bit on the table with the fact that we need health financing to create a dynamic, right? I started to talk about that, but I take your point. I take your point. Christoph?
I tried to respond quickly and combine that also with your last, question to Grace. You challenged us to think also about the speed of, how quickly can money be made available, right? And there's the constant challenge between the speed, but also then the accountability and the participation. And you can't have all at a maximum at all times. But there are times when you need to emphasize speed, when you respond to an epidemic or to a crisis, and then you automatically compromise on the accountability and the participation. You can't consult everybody before you react to that. However, when you're building health systems, when you're talking about the sustainable health financing, then speed, is decreased in importance, and you emphasize much more the kind of consultation, the participation, community participation, democratic processes, and the accountability that you need to have. I think what we need in our systems is the right flexibility for that the systems can respond quickly when required, but have then also the processes for the accountability and the participation when you think about the longer term. And I don't think we emphasize that maybe enough, but I think it's very important that we think of systems that have that flexibility to respond to different challenges at different times.
I would like to add Christoph's point by adding more about context. So when we talk about health financing, sadly, because although it is very technical, it is also very political. Different countries have different contexts when they design their health financing mechanism. And most of the countries design it by imagining peaceful time, where all of the professional organizations come together and in agreement, all of the subnational governments come together and in agreement that money can come, that providers can be paid within 2 weeks, whether they are in the capital city or in the most remote area. So I think that context plays a role in having to redesign or be reactive somehow into the current dynamics. For once, I know in Indonesia, the background of designing the health system, although that was needed at that time, that is also a very political decision, transitioning from one government to another 10 years ago. And the design was haste. It was not well thought of. The national health system always scrambling for more resources. And it becomes even more so because of the pandemic. So it might come off as reactive. We would, in an ideal world, design it to be more, have a foresight ability into our health financing mechanism. And I hope, since we are talking about health system resilience, we are also talking about health financing resilience, that this time to rebuild can be done to prepare better, to not be reactive, but to think ahead and to really design the future of health financing in a better way, knowing what we know today.
Jack, may I also just? Yes. I think part of what Christoph was talking about, like with the pandemic fund is designed to help build human resource capacity at the at the national level. It's supposed to help with surveillance systems and all. Those are going to help at least with the detection, the prevention, and should things escalate, then the reaction in terms of the response. So I think it's not just about how the monies are being raised, it's also about what it is being raised for. I know discussions within the G20 will be looking at the surge capacity funding, but at least at the moment, at least from what I have seen, some of the priorities are really about how do we be able to put in place systems now that help us to detect better, to prevent, and should we escalate then to respond. The other thing is about, with the PFM system, you only have one PFM system, and it should be able to carry you through the steady state and through the crisis state. And so how you design it in the steady state will determine how it responds in the crisis state. If you design it only for the steady state accountability only, that is what you'll get. But if you put in place the mechanisms that right now help you, should you have any escalation, then that helps you with the preparedness better. And that's where the legal instruments come in. That's where the funds, the contingency funds come in. That's where the skills and the awareness of what is going on within the PFM system happens. Because I can tell you, at least within some of the states we've worked in, Maulik and Tushar here can attest, just even the basic understanding of the PFM rules within the health sector is a problem. And so knowing what is available for you, even in that crisis mode, would become a bigger challenge. So just even understanding, okay, how do the processes currently function? I think just those small things, I think, can make a big difference.
I don't know if you're happy with that answer, Vijay, but you know...
no, I'm not. Let me rephrase the question. You know, in immunology...
I can read your...
Right, in immunology, we have a concept where, you know, the body doesn't have a limited response system to a limited challenge. The body has the ability, by recombination, to have a repertoire of responses that are almost infinite, right? So, and you are pretending that you can predict the next challenge. You can't. Nobody can, right? Now, we couldn't predict a lot of things. A volcano, a super volcano exploding, for example, right? So when we are talking about a resilient system, if the system does not have the capacity to adapt very quickly, it will die. So that's the point. And I'm saying that we've talked a lot about this and building redundancies and capacities. What I don't hear is the autocatalytic, autopoietic, responsive, adaptive system. That's what I don't hear.
Okay, well, fair enough. But I think we all agree with you. We all agree with you that we need that. And you know, I heard Mushtaq yesterday and today talk about the challenges in his country where there are line items, and you know, he could accept more money into his country, but they wouldn't be able to absorb it because they don't have the flexibility. They're not set up through their line item budgets to absorb that money, to be flexible and to be responsive. So, you know, I think this is a challenge in India as well. You know, I used to work in Eastern Europe. They had 24 line items. 24 line items. I come to India and I ask, how many line items do you have? Oh, we have thousands. Thousands. You know, how does a manager have the flexibility to respond when you have thousands of line items? I couldn't do it. So, I mean, I think, you know, you raise a valid point. You raise a valid point. So I think we really need to think about that responsiveness aspect.
Well, thank you at least for
still not happy.
No, thank you at least for saying this requires real intelligence and not artificial intelligence.
So job security for us, is that what you're saying? Okay. Uma?
Should I?
Yes, please.
I am not going to sum this up. It is absolutely incredible to hear so many countries, so many kinds of systems that came together, and the kind of responsiveness that we had this morning's session. Finance is a daunting thing for me personally. And I don't think that I saw that it was less daunting for everybody else in this room, because the way to finance, how we go about it, what is it that it will bring, how are we going to bring it back, do we risk, do we pool, do we actually share in some way, or do we actually go beyond? I don't think we still have answers, but we have a learning journey that has begun, and a journey that's going to help us understand what are those things that we can make actionable as we go forward. I am going to request Tushar Mukashi to please come up. He works with us in research and does a lot of finance and costing. So he's the right person to ask Jack to facilitate and felicitate people, which he did.